Okay, so I'm going to start things off. Let's go ahead and get started. Welcome, everybody. Good morning. And welcome to the March 2022 Tarjan Center Distinguished Lecture Series. I'm Jasper Estebio, our Director of Training, and it's a pleasure to be here with you all and an honor to be introducing our speaker for today, Dr. J. Thomas Megerian. Before we get started, reminder to type all your questions into the Q&A feature for our speaker to answer at the conclusion of our talk. And please remember to complete our evaluation survey, which will be sent as a Qualtrics link in our chat. So Dr. Megerian completed his medical degree at the Northwestern University Medical School. He's the medical director and licensed pediatric neurologist at the Thompson Autism Center at CHOC, where he works closely with a team of clinicians to provide a variety of medical care, assessment, psychological, and neurobehavioral treatments for children and families affected by autism and other neurodevelopmental disorders. He also has extensive clinical experience with epilepsy, Tourette syndrome, and tic disorders, chronic pain syndromes, obsessive compulsive disorders, anxiety and mood disorders, while conducting research in ADDs and updating diagnostic approaches to evaluation of ADDs within the department. Dr. Megerian is also working with Yamo Pharmaceuticals as the CMO and Senior Vice President of Clinical Research and Kuzani Pharmaceuticals and Cognito Therapeutics as an advisor for research and developmental programs. Please join me in welcoming our speaker, Dr. Tom Megerian.
Thank you so much, Jasper. I appreciate the opportunity to address this group and hopefully tell you about what we've been doing at the Thompson Autism Center at CHOC, especially in the realm of how we're working with kids with autism right now and also other neurodevelopmental disorders and co-occurring disorders that are very common in this group. By way of disclosure, I think Jasper actually mentioned a couple of activities I'm involved in that are not directly related to what we're going to talk about today, but are in the autism space. So what I'd like to hopefully cover with you all is an overview of the co-occurring disorders that occur in autism spectrum disorders, some epidemiology of those co-occurring disorders, and then the model that TAC, as we call the Thompson Autism Center at CHOC, that we have created for multidisciplinary care of those co-occurring disorders. So probably not surprising to many of you, but about 95% of children with autism have at least one co-occurring disorder. On average, each child with autism has about 5 co-occurring disorders. That's obviously an average, so some have 1 or 2 and some have 8 or 9. The most common ones I've listed here include anxiety, ADHD, sleep difficulties, obsessive compulsive disorders or behaviors, seizure disorders, problems in the GI tract, and allergies. And we'll go over some of those actually in a little more detail as we progress here. So to start off with a little case study, and this is something we'll go into more detail in a little bit, but this is about a child named Joseph, who's a 14-year-old male who has level 1 autism and presents to our clinic with symptoms of inattention, hyperactivity, obesity, also has depression with some features of hypomania and epilepsy. And he's been treated for his epilepsy with levetiracetam or Keppra. He's also begun having headaches over the last 6 months, and these headaches are associated with photophobia, nausea, and vomiting. He also has an history of intermittent vomiting, even preceding the headaches, with intermittent diarrhea and abdominal pain. He does like to drink a lot of chocolate milk and also eats cheese pizza every day for lunch. His IEP, which is in place, allows him to be in a mainstream classroom with pull-out services, although he does express sadness over not having friends. And his mom is not sure if his current IEP is sufficient for his needs. The co-occurring appointment is scheduled on the particular day with psychology, psychiatry, neurology, and gastroenterology. So we'll come back to that case study, but I wanted to kind of put that out there as a framing for really what we're going to talk about, which is co-occurring disorders in the face of autism. So one thing I think we all know on this call, that autism is not a single disorder. It's really, as Geschwin and State have mentioned, it's a common syndrome that comprises, in part, several hundred rare disorders. An analogy would be cancer, anemia, dementia, right? There are many causes for anemia. There's many causes for cancer. There's many causes for dementia. We may think of, when we think of cancer, lung cancer. We may think of, when we think of anemia, as iron deficiency anemia, and dementia as Alzheimer's dementia, but there are actually many other causes of each of those diseases. And if we don't understand or realize what we're actually studying when we do research on these individuals or individuals with these entities, we may be studying the wrong treatments or the wrong diagnosis, wrong diagnostic methods. If we don't, for instance, differentiate between anemia due to iron deficiency and anemia due to sickle cell disease or beta thalassemia. Same thing goes with cancers and dementia. So ASD, of course, is just a description of symptoms that occur from a multitude of different disorders that probably have some overlap in their final common pathway toward their pathophysiology. Really, there's been over 100 genes now that have been implicated in autism. And what's really important to remember is that many of those genes that are implicated in autism also raise the risk for other non-ASD neurological, neurodevelopmental, or psychiatric disorders by virtue of shared genetic underpinnings. As an example, there are many genetic and environmental effects that are common to ASD and ADHD. There are also many genetic and environmental effects common to learning disabilities, tic disorders, and developmental coordination disorder that are also shared in common with autism. Probably one of the areas where we've learned so much about this is when we studied when researchers have studied monozygotic versus dizygotic twins with autism. And what we see in monozygotic twins who have autism is a much higher prevalence of these co-occurring disorders such as ADHD. So in a monozygotic twin pair, the probability of having a diagnosis of ADHD co-occurring was about almost 50%. So if one SIB had it, there's 50% chance the other would have it, compared to dizygotic twins, where the comorbid occurrence was only 15%. So we see the shared genetics having a great influence. And then also, because 15% is higher than the general population, there's some overlay of shared environment as well. We also, these investigators, Lichtenstein, who did looked at these twins, also saw higher rates of tic disorders and developmental coordination disorder. In another study by Lundstrom, who looked at 272 patients with ASD, he found that these investigators found that more than half had 4 or more co-occurring disorders. Only 4% did not have a co-occurring disorder. The overall prevalence of psychiatric and behavioral disorders are higher than in the general population, again, recommending or referring to the fact that there's a common genetic etiology for many of these disorders. And again, as I mentioned before, early studies showed that monozygotic twins that were discordant for autism still shared a higher rate of cognitive disabilities in terms of cognitive dysfunction, coordination disorders, language disorders, and or hyperactivity. So even though they were not concordant for their diagnosis of autism, they still had higher rates than would be expected for these other disorders. And again, in the dizygotic twin studies, only about 10% shared motor milestone and learning disability delays. And when they looked overall at in this cohort of 272 patients, the rates of co-occurring disorders were 79% for ADHD, 75% for LD. Tic disorders occurred in about a third of the patients, oppositional defiant disorders a third, OCD in about a quarter of patients, and composite disorders, which really kind of included any combination of developmental coordination disorder, executive dysfunction, or visual spatial dysfunction occurred in about 3/4. So in preparing for this talk, I went ahead and did some review work and also looked at some of the reviews that are out there to kind of get a sense of what we see in children with autism in terms of co-occurring prevalence of other disorders. And I broke it into neuropsychiatric and behavioral disorders and medical disorders. So you can see that the point prevalence estimate that was most common was about 28%, namely about 28% of kids with autism also had a diagnosis of ADHD. The range of studies that are out there is quite wide. It's about 30%, 28%, all the way up to 80%, depending on the cohort that was studied. Interestingly, if you look at the opposite of that, right, looking at what's the percentage of patients with ADHD that have ASD, it's a pretty similar number, about 20 to 50%. Depression occurs in about 11%, with a range of about 1 to 52%. Interestingly, increased self-injurious behaviors have been known to be associated with the presence of depression. So treating the underlying depression, if you think it's present, may have an effect on decreasing self-injurious behaviors. Anxiety is present in about 40% of kids, roughly about 40% of children, preteen, and about 35% of adolescents, with a range of about 13.5% all the way up to 85%, again, depending on the cohort that was being studied. It's interesting to note that many studies showed that increased anxiety is likely to be associated with a higher IQ and a lower ASD severity. Possibly one theory is because of the greater ability to have insight over self-identified differences from peers. And social anxiety in particular was the most prevalent subtype. Mood disorders, bipolar, and other mood disorders that are not depression are present in about 18% of individuals, true bipolar in about 5% of individuals with autism, with a range of about 4.5% to 37%. This is also associated with higher functioning children, and the actually initiation of bipolar mood disorders may also cause a regression. So one thing to look for in the kids that you see who've got sudden regression, besides looking for neurometabolic etiologies, is to look for onset of depressive or mood disorders. Sleep, of course, is very, very common in sleep dysfunction in autism, with a pooled prevalence in a recent study, which was actually quite low. So a recent meta-analysis did a pooled analysis and said about 13% of those individuals with autism had true sleep disorders versus about 3.7% in the general population. But more common numbers that are cited are really about 50 to 80% of kids with autism will have some form of a sleep dysfunction. And there's many, obviously, different types of sleep dysfunction, but over here you can see on the right that usually these are broken down by what the total sleep time is. So kids with autism on average have about a 30-minute less sleep time than the typically developing child. Latency is about 11 more minutes to fall asleep. Their efficiency is about 2% less than a child without autism. And some sleep issues, of course, may be confounded by other issues and other problems, which we'll talk about. Obsessive compulsive disorder, about 17.5%. Disruptive impulse control or conduct disorders occurs in about 12% of kids with autism. Tics, any type of tic, either a simple motor tic or chronic vocal tic, occurs in about a quarter of kids with autism. True Tourette's in about 11%. Eating disorders do actually occur pretty fairly often, or I'd say not fairly often, but more often than you would expect, about 8% of times in prevalence rate in kids with autism. And intellectual disability, of course, is highly prevalent, about 50%, with a range of about 25 to 70%, depending on the study that is being cited. Often children with intellectual disability obviously have more severe social, behavioral, and motor issues associated with their ID. GI problems, switching over to the medical side. So GI problems are probably one of the most common disorders that we see on the medical side for kids with autism, about a quarter of kids. And this is broken up pretty evenly between kids with constipation and kids with constipation and abdominal pain. The range, though, again, in studies that have been cited, goes up to 90%. So in some cohorts, nearly 90% have reported at some point having gastrointestinal complaints. And again, a lot of times we do see that GI problems are correlated with the severity of autism. The most common that we see are constipation and diarrhea. Epilepsy is about 12%, with a range according to various studies going from 5% to 40%. This is in contrast with about 2% of the general population that has epilepsy. The risk of epilepsy co-occurring in autism is 21% versus, so this is the other way around. If you have epilepsy, the risk of co-occurring intellectual disability with autism is about 21% versus 8% if you don't have intellectual disability. So you get a much higher, almost a doubling of the incidence of epilepsy if intellectual disability is present in the setting of the autism. And the female to male risk is 35%. So it's inverse of what we tend to see with the risk of autism. Risk of autism, of course, seeming to be higher in males than females, but opposite for epilepsy. Cerebral palsy has been defined or identified in about 5% of kids with autism. And this, of course, is not necessarily the cerebral palsy that we think of, a person who's wheelchair bound. It could just be someone with mild spastic diplegia, increased tone in the lower extremities with increased reflexes and clonus. Interesting, children with co-occurring cerebral palsy and ASD do tend to have more repetitive and restricted behavior problems than those without cerebral palsy. Migraine, very common in autism, much more common than I think people realize, and probably one of the reasons we do see kids getting upset or displaying agitated behaviors. So always important to remember to look for causes of those behaviors and think about migraine as one of them. Getting a good family history helps with that. Seeing if there's any first degree or second degree relatives with migraine should raise a suspicion that a child who's maybe engaging in head banging without frustration or without a known trigger could be displaying migraine. Talk a little bit more about GI problems, which I think part of the reason being that they're one of the most common problems, but also because of their complex relationship with other disorders. So chronic constipation and chronic diarrhea are the most common, followed by abdominal pain, followed by gastroesophageal reflux. Over here on the right, you can see a summary of studies that looked at GI problems in autism. And again, you can see several of them were really well over 50% prevalence of GI problems in this population. Some of at least one going up to 90%, but another one over 80%. And GI, the interesting thing, or I think the most important take-home lesson is to realize that GI disorders worsen other behaviors. They can cause sobbing, screaming, irritability, agitation, aggression without known triggers. And again, much like the situation with migraines, very critical to look at what might be causing those behaviors when we don't have a good behavioral explanation. In other words, it's not because the child's being denied a preferred activity or because the child is being asked to perform a non-preferred activity. So children who are expressing frustration, irritability, and agitation without known triggers, one should think about GI problems, especially if they're paroxysmal in onset and have a limited duration. GI problems also often disrupt sleep. So when sleep is disrupted, important to think about, could the source of sleep disruption be coming from a GI disorder such as reflux. Reflux tends to get activated at night, and so kids who wake up frequently in the middle of the night should be evaluated for reflux. I put together a little bit of a cartoon here to kind of show that GI problems can increase anxiety, and anxiety in turn can also increase GI problems. We know that the gut is very sensitive to stress and anxiety. So a child with anxiety could in fact display some of that anxiety through the GI system. It may not be the GI problem causing the anxiety, it may be the other way around. But you can see, if you think about GI problems and if they are on an increased trajectory for a given individual, that can lead to poor sleep. The poor sleep in turn can lead to increasing anxiety. There's also a direct relationship with GI problems leading to increased anxiety. Increased anxiety, of course, leads to increased irritability. So does poor sleep. which of course then can lead to worsening of those GI problems. So the interplay between GI problems and a lot of behavioral disorders is an important one to recognize and to keep in mind. Other medical problems that we see pretty common in autism are allergy symptoms. Urticaria in particular is higher by about 50%, almost 50% in children with autism. Urticaria is about 8.5% versus 6% in controls. But again, a wide range of reported incidence of urticaria, 9 to 91%. And this, of course, goes along, urticaria and asthma and allergic disorders go along with the notion that for some individuals with autism, immune dysfunction may be at play. Asthma is about 21% prevalence in kids with autism. Any type of allergy, eczema, skin allergies, food allergies are also higher in kids with autism, 15%. For eczema and skin allergies, food allergies, about 10%. There are some studies that have said that really allergies are probably asthma and atopy are not increased in autism, but many more, I think, are identifying an increase in prevalence in these disorders in kids with autism. There are some indications that early presentation of atopy in young children might be associated with a higher incidence of autism. Hearing impairments, 1.6% of kids with co-occurring hearing loss have ASD, meaning ASD by itself, not as part of a syndrome. About 5, almost 6% of kids with hearing loss have ASD as part of a syndromic presentation. Other way around, other way to look at this is 9% of kids with hearing impairment were noted to have a diagnosis of autism or autistic symptoms. Vision impairment present in about 23%, some form of vision impairment. And we're not talking necessarily about visual acuity, although that's part of it, but also we see strabismus as being very common in kids, much more common in kids with autism than in the general population. And again, conversely, if we look at kids who present with vision impairments, we see that anywhere from 7 to 20% of those kids might have autistic symptoms or a frank autistic diagnosis. So what's the cause of these co-occurring phenotypes? We kind of mentioned before the genetic overlay, which of course does make a lot of sense, but how does this happen? What's the underpinning for this? So one model that was put out a few years back, actually only a couple of years ago, which I actually found to be pretty enlightening, was you can think about, if you think about different phenotypes of autism, how the child presents, what their symptoms are, what their level of severity is, what their co-occurring symptomatology are. You can think about it in 3 different ways. In the first way, there's a child who has a genetic and environmental risk, and that risk leads to a mechanism that produces both a medical condition, in this case could be GI problems and autism, and the underpinning is really from a common etiology, a common genetic or environmental insult that has caused both conditions. The other way to look at this, and that produces a particular phenotype, we call it just for argument's sake, phenotype A. Another way to look at it is kind of a double hit phenomenon, right? So you've got a medical condition with a genetic underpinning that may cause a autistic set of appearances. And then you may have a genetic or environmental risk that by itself will cause autism. And if you put these two together, and that will cause a phenotype, I call it phenotype D, the medical condition that can lead to an autism phenotype. And an example here might be premature birth. And that particular phenotype presents with, or that particular autism presents as phenotype B. But if you have these two features together, in other words, say a child born prematurely with some periventricular leukomalacia, plus an environmental risk factor or a genetic risk factor, and you combine them, they present with a different phenotype called phenotype C. So this is a kind of a complex way of looking at the interplay between a child who has a medical cause of autism by itself or a genetic cause of autism by itself, which produce 2 different phenotypes, or the child that has both of these insults together. If you look at the Autism Developmental Disability Monitoring Network in a recent publication in 2018, they looked at the rates of co-occurring diagnosis over an 8-year period from 2002 to 2010. And they noted if they looked just at 8-year-olds, they saw a pretty substantial increase from less than 1 to over 1 co-occurring diagnosis occurring in that 8-year period. So a pretty significant increase in how many co-occurring diagnoses were occurring in 8-year-olds. And that was, of course, about 12 years ago, and only was looking at 8-year-olds. So if you put all those years together, plus you add another 12 years of watching this trend, you can see how we're getting up to 3-4 diagnoses at a time for kids with autistic spectrum disorder. We took a look at co-occurring conditions in Orange County in particular, and the kind of data analysis we did looking at claims data in Orange County. First of all, verified that new cases are about 450 per year in Orange County, and that's added on top of the existing number of these are children 18 and under with autism, which is about 10.5 or 10,500 kids with autism. 86% of those kids with autism are under the age 12. And of this group, of this 10,500, the vast majority are seeking, they have comorbidities and they're seeking care from pediatric medicine, neurology, and other subspecialists. And you can see the majority of that care is coming from pediatric medicine. So most pediatricians are trying to manage the GI problems, chronic constipation. They may be even managing things like ADHD. Neurology sees a large percentage of these kids. Psychiatry and behavioral health see about 17%, which is a little surprising given the fact that the rates of psychiatry and behavioral health problems in this population are much higher than 17%. And then other specialists such as GI, ENT account for about 25% of the care. The most common diagnoses, as we saw in the summary tables that I showed, are ADHD, developmental disorders of speech and language, urinary incontinence, epilepsy, other specified disorders of the brain, and included in that would be things like migraine disorder, tic disorders. Attention deficit disorder of the predominantly inattentive type is up there, but not as high as the combined type, and then constipation. So what are we doing here at Thompson Autism Center at CHOC? Our goal was, when we opened the center, was to provide a medical home where that could provide wraparound care for the most common medical diagnoses. And we were looking to provide for kids with actual disorders, but also are looking to provide what I'd call preventative and surveillance care. So especially in the areas of eye care, routine eye exams, routine dental care, and routine ENT care. So we're building, we're in the process of building in care for these particular areas of preventative care. Right now, dental is the only one that we aren't doing, but we're trying to build specialty care for the other disorders as well. The other preventative care as well. The disorders that we see really fall into 4 buckets. So the neuropsychiatric behavioral bucket, which involves specialists in psychiatry, psychology, developmental and behavioral peds, and neurodevelopmental neurology, treating the targeted diagnoses of ADHD, depression, mood disorders, OCD, agitation, and aggression. GI disorders, targeting the disorders I mentioned before, and then neurology, which targets tics, epilepsy, sleep disorder, and neurometabolic disorders. We're opening a combined neurometabolic autism developmental delay clinic this summer. And then dental services. We have a great partnership with Healthy Smiles here in Orange County, and they actually are in the process of bringing services in-house into the center. But right now they actually bring their big mobile unit to the center monthly to offer services to our families and children. The other services that we provide are the FAST program, which is our Families, Agencies, and Schools Together program. And that allows kids with school IEPs who families that need education about what their IEP is providing, or families who want a second opinion about whether the IEP services are sufficient, they can speak with our and be evaluated by our FAST coordinator and director. We also offer transition services to adulthood, focused more around employment, vocation, and living skills, and then resource assistance and social work. So the model and the reason behind the co-occurring service model at TAC was really to foster three critical areas that we think are missing in the current model of the way we were providing services in a more fragmented way at CHOC. One is expediting communication between specialists at the time of visit. So previously, when I was seeing patients at CHOC, I might see a patient that had GI problems, and then I'd want to reach out to the GI doc because I might be thinking of starting a medication that might help with, say, weight gain if weight was an issue, and I wanted to see if they would be willing to remove the medicine they were using for weight gain so that we weren't overdosing someone for appetite stimulation. And that would have to go through a message system, through our Cerner. You have to wait for a response. And everyone, of course, is very busy, so waiting for those responses could take days, even weeks. In the meantime, the family didn't get an answer about the treatment plan. So expediting communication between specialists is one of the goals of a co-occurring service model. Efficient care. And this really was about making it easier for families to get all of their services, not just in one place, although that's a big part of it, but also at one time or in as few visits as possible. So really trying to get as many service lines available to the family for a single visit so that the child misses less school and less therapy time, and the parent misses less work time. And then coordinating the care, agreeing on aligning on a care plan between the specialists, between the family, between social work and resource specialists, bringing all of those folks together so that at the time of the visit, we could come up with a single unified plan for the family. So let's go back to our case model, our case example, because I think that's probably a great way to show, best way to kind of showcase what we're able to do. So Joseph, if you remember, was a 14-year-old male with level 1 autism who presented with symptoms of inattention, hyperactivity, obesity, depression with some hypomania, epilepsy that was treated with levetiracetam. He'd also begun having headaches that were associated with photophobia, nausea, and vomiting. In addition to the vomiting, he's also had a history of intermittent diarrhea and abdominal pain. He has a diet that consists largely of chocolate milk and cheese pizza. And he has an IEP, but mother's a little concerned that the IEP isn't providing sufficient services, especially in the areas of socialization opportunities. And the co-occurring appointment was with the specialists that I mentioned: psychology, psychiatry, neurology, and GI. So after the appointment, which occurred on a given morning, and the family got to see GI, psychiatry, and neurology, as well as psychology. The GI clinician, psychiatry, and neurology clinicians got together and really addressed several issues. One, levetiracetam is a medication that could be contributing to the child's hyperactivity. And Depakote is another medication that could be used for this particular seizure type that also would have mood stabilization features. And also is a great prophylaxis for migraine because it seemed from the symptom symptom presentation that this child was having migraines. And so being able to put that together really helped psychiatry and neurology move away from a medication that might have been making symptoms worse and agree on a medication that would address both the mood issues, the epilepsy, and the headaches. Gastroenterology, in fact, was concerned that the abdominal pain and vomiting could be abdominal migraines, and so was thrilled with the idea of trying Depakote to see if that would actually address some of the GI symptoms that the child was exhibiting. Psychiatry and GI also decided that the ADHD symptoms would probably not be best treated with a stimulant, since that could make the diarrhea worse, and instead decided to go with atomoxetine, which might also address some of the depressive symptoms. The gastroenterologist requested a stool sample and blood work to rule out celiac disease, recommended diet alteration to see if the excess dairy intake was contributing to diarrhea through lactose intolerance. Psychology decided after meeting with the family that child would benefit from weekly psychotherapy to address the anxiety, depression, as well as executive function dysfunction skills, utilizing some coaching, and also offered to have the parent and child join a peers group starting next month, which also would help with not only counseling, but also introducing the child to peers that he or she might be, or he might be able to rely on for further social activity. The FAST director, Families, Agencies, and Schools, joined the meeting at the end to meet the family and offered to further contact them so that they could review the IEP and discuss whether there were additions to that could be requested from the school. The nurse went over the instructions with the family from the co-occurring team, went through in great detail the recommendations and made follow-up appointments for the co-occurring team in 12 weeks. And the patient in the meantime was scheduled to come back with a nurse practitioner for a med check in 4 weeks. So you can see here how the group was able to work together to address the co-occurring symptoms. And that's the model we've been using. And I can say that since we opened in March 2020, you can see we've had about over 3,500 visits for co-occurring disorders. These are not unique patients, but visits amongst our patient population. Initially, a lot of it was telehealth. So we did about 2,600 by telehealth and 903 in person. You can see that the red line, the orange line here is actually the in-person. You can see in-person co-occurring has really picked up since the summer and has surpassed telehealth visits, but of course, the lion's share of what we did was telehealth. And you can see here our top diagnoses. So these are the top 20 diagnoses that we see in co-occurring clinic. And these are based on unique patients. So these are individual patients with these disorders. The top being sleep, ADHD, anxiety, epilepsy, behavioral disorders, mood disorders, and constipation. Another quick case study we can go through is about a little 5-year-old girl, Tamara, who has ASD and presents with feeding difficulties, fine motor delay, constipation, poor weight gain, irritability, self-injury, oppositionality, and prolonged sleep latency. The family's been using diphenhydramine to help with sleep. ABA is in place, and the appointment was made to see gastroenterology, the neurodevelopmental specialist, the sleep specialist, psychology in the co-occurring clinic. The team confers and during the appointment decides on the following. Neurodevelopmental neurologist will start a trial of risperidone for the irritability and for the SIBs, as well as the oppositional behaviors. That will also address GI's concern over weight gain because risperidone does have a tendency to stimulate appetite and obviates their need. They were going to actually start ciprofloxacin, so the child would have been on 2 different medications, but because we worked together, we were able to simplify the medication regimen. Gastroenterology is also going to start Miralax and also recommended supplemental Pediasure, and a referral was made to OT, to an OT provider that could provide both therapy for the fine motor deficits as well as oral feeding therapy. So we were able to make a decision about referring to an occupational therapy provider who specializes in both feeding and fine motor, as opposed to having one who really is only comfortable with one of those entities. The sleep specialist advised a trial of melatonin to help with sleep onset, and psychology agreed to work with the family on improving sleep hygiene, behavioral sleep hygiene, as well as working with parents and parent training on how to handle the child's irritability, oppositional behaviors, and SIBs in conjunction with the ABA therapy team that's in place. And the follow-up was made to be in about 8 weeks. So how are we doing? Well, the best we can tell is really through our family feedback. And you can see our scores for family satisfaction have really been over 80%, sometimes getting up there 97, 95%. We dropped to 83% last quarter, but overall, I think we're doing very, very well. And some of the comments that we've gotten, I've listed here that really are about the co-occurring clinic. And I think the message that we've gotten is really that people appreciate the ability to have all of their care in one place and when possible, even at one time. And I think, you know, the goal, that's really what our goal has been. And our expansion, our plan for expansion includes adding more services, as I mentioned. ENT and ophthalmology are ones that we want to get over here. And also we will be bringing on neurometabolics this summer as well. And with that, I'm going to open it up to questions.
Thank you so much, Dr. Megerian, for that wonderful talk. And I think it really highlights the need, the critical need really, to provide co-occurring services for so many of our patients and families. You know, I think every single time I see that prevalence rate of 95% of children with autism have a co-occurring condition, and I think it takes me back every single time, even though anecdotally and in the research, I think that is you know, very much the case. So thank you so much for such a wonderful, enlightening talk. I want to remind all of our attendees to please put their questions into the Q&A so that way we can address them. I think to start us off though, Dr. Megerian, I'm curious in terms of this co-occurring care model, which is so wonderful to have essentially a one-stop shop for our families, you know, who are already overscheduled. There's so many therapies. How do you help parents navigate how to prioritize all of these treatment targets, right? They get a report that gives them 20 recommendations and, you know, on top of the 5+ co-occurring conditions, how do you navigate, you know, what to prioritize for each patient? Yep, you're muted.
Oh, there we go.
Yeah, you're back.
Great question. I would say we do, so when, especially on the behavioral front, right? When kids present with multiple behavioral disorders, we usually will say, you know what, it's really complex. Let's pick the top 2 or 3. And so, you know, obviously in the case studies I gave, I was trying to highlight the complexity, but, you know, we would probably, in reality, in that case, pick like the 2 top things that are most problematic and interfering most with the child's ability to learn or interfering with the family function, frankly. So we kind of pick what's most important to the family and what's most important to the child when they can also kind of bear witness to that as well. If it's, and our GI docs, I have to say, are really good about the same thing as well. They're usually pretty good about, you know, look, there's like the case of, you know, chronic diarrhea that one patient I had, right? We really could say, well, you know, we're going to do blood work and we're going to schedule for an endoscopy because there could be, you know, you might want to check for H. pylori, but we try not to do that, right? We try to just say, let's just take this step by step. And really, again, how we decide what comes first, even on the medical side, really is guided by what the family says is most important.
Absolutely. Yeah, I love always integrating a partnership with families and saying, what are your priorities, right? We have so many components here in medications, different specialists to see. And so I do think that it's so important to really partner with them and say, what's the most important and impactful for your family's lives? Wonderful.
I think we usually get from them before they come in, we get a list of what concerns them. So if we've got a list of 10 things, right, we often will say, you know, we're not going to be able to do all of this, and you don't want us to do all of this at once. So tell us what's most important.
Right. And you know, so we also know, in addition to the number of co-occurring conditions that they increase over time, that those co-occurring conditions you know, tend to also increase with age, right? We don't necessarily see anxiety or mood disorders as often in younger ages, but that increases over time. So for the patients that you see at TAC, how do kind of the prevalence of comorbidities change across the age range?
Yeah. Well, I mean, I'd say we've only been open for 2 years, so it's a little bit harder to see that, but we do see we do see our kids evolve, right? And
Mhm.
especially if they change schools, for instance, there are some times where, there are big, I'd say big jumps where
Mhm.
co-occurring conditions, I wouldn't say appear, but they become unmasked.
Mhm.
So it's usually when a child goes from, say, elementary school to middle school, or
Mhm.
from middle school to high school, then sometimes things like ADHD will become unmasked. Anxiety might become unmasked during those big jumps. Puberty, of course, brings on a whole nother set of opportunities for new disorders to start. So, for instance, migraines often occur, in kids who, if they have a propensity toward migraines, a lot of times you'll see that migraine picture start around puberty. Tic disorder, same thing. We often see a burst of tic diagnoses at ages 12, 13, and then a change in prevalence or persistence or frequency or severity when they hit 18 or 19. And so there are changes, and it's not actually just, it's in both directions, right? Things
Mhm.
appear, so co-occurring disorders appear, and other ones get better.
Mhm.
So you have to kind of be constantly vigilant for making sure it's not just about starting treatment, but also stopping treatment when it's not
Mhm.
needed anymore.
Absolutely, right. It's like, even with just diagnosing of autism, we often say that we might not see some of these symptoms until social demands or
Right.
whatever is happening in life unmask, as you had said, these challenges. Great. I think another question that I had is, for families that come in, right, are these, because these are co-occurring conditions, and so is it that that patients get referred once they already have these co-occurring diagnoses, or is it at that initial diagnosis a clinician then refers to the co-occurring clinic, but kind of what is that pipeline for referrals for you?
Yeah, that's another great question. So there's yes to all of those, right? So we get a lot of kids who already have the diagnosis of those co-occurring conditions, and they want the care kind of consolidated. Or it's, for ADHD, for instance, or anxiety, they again have that diagnosis. We get a lot of kids who get referred because um, unfortunately, there's a lot of folks who won't take a child with
Mhm.
anxiety or ADHD if they have autism. So there's especially at the county level, there's a lot of rules about whether or not they'll see kids with autism. So if autism is
Right.
the primary diagnosis, then they'll say we can't see you here. So we get those kids who, yes, you've got anxiety, we've already diagnosed it, but we can't. You also have autism, so we can't see you. You need to get
Mhm.
follow-up elsewhere. We get that. We get kids where it's there's a question of, and they want to know if there's, why this child's having abdominal pain. So they'll send them to us because they have autism, and we'll schedule them for GI and maybe a neurodevelopmental
Mhm.
specialist to see them as well, especially if there's a behavioral problem. We haven't started taking kids who basically have autism and say only GI problems
Mhm.
by themselves. Usually those kids still go to GI because if everything else is okay, they don't necessarily, and they're pretty high functioning, they don't necessarily need to be, at a center like ours. Ours is really kind of more for the kids who've got a little bit more complex presentation.
Mhm.
So they've got autism that's pretty active, and they've got GI problems and or
Mhm.
sleep problems. Epilepsy, our neurology epilepsy folks have been managing a lot of kids with autism for years, but
Mhm.
they'll tend to send them to us when they want their epilepsy to be cared for here, as well as some of the neurobehavioral disorders.
Mhm. Absolutely. I think it's so wonderful to be able to provide essentially a home for these patients and families,
Right.
because as you had said, oftentimes families are denied services because as soon as clinicians or centers or agencies see autism, they say, that's outside of our purview, that's out of our scope. And so it's so wonderful to be able to provide a center hub for so many of these families.
Yeah.
I'm going to jump into some of the questions in the Q&A. We have a question from Deborah Morin. I'm a parent. Do these studies note if the patient was on medications, or are these non-medicated kids? Is it possible that some of these comorbidities could be contributed to medications?
Yeah, I don't know the answer to whether they're on medications. Usually, because they're assessing they're assessing the children. They're usually have been diagnosed before the medication started. So if someone comes in with GI problems, it's usually they're seeking help. So in most of these studies, it's because what the child was seeking help for. So they're seeking help probably before medication started. But I can't answer specifically for each of those studies which ones had kids who were on meds and which one didn't.
Okay, thank you. From Rhonda Copito, are you familiar with cyclical vomiting syndrome, and is it associated with abdominal migraines?
The answer is yes and yes. So cyclical vomiting can be associated with abdominal migraine. In fact, that's one of the items in the differential diagnosis for cyclical vomiting, is that in fact, it could be abdominal migraine, and it's often treated that way as one of the treatment methods is to try anti-migraine drugs.
Okay, great, thank you. Let me see here. Okay, great. From Tiffany C. They say, thank you for the wonderful presentation. I'm very excited for the model as a one-stop shop. My daughter's 21. We're also going through adult transition, and she does have comorbidities. We've always struggled to get multiple appointments in one visit. How does it work with adults in this population as a one-stop shop?
Yeah, that's a really great question, Tiffany. And we've actually been talking about that we need a mirror version of what we do on the adult side. And I think there are people interested in finding a place like that or developing a place like that. So I have heard even our donors have kind of talked about that. Wouldn't that be great? I don't think it's at this point anything that we're doing yet, but we are trying to, at the very least, we're trying to find, and CHOC in general has been across the board, not just with autism, has been trying to find adult specialists who are willing to take our kids, both kids with neurodevelopmental disorders, but kids who've got, type 1 diabetes or congenital heart disease or cystic fibrosis or cerebral palsy. Finding the adult practitioners who are willing to take care of them is an ongoing issue. We've got a whole transition program that we've built at CHOC to address this. And we're trying to work with, we're trying to find adult providers who would be willing to take our kids as they age out of our program.
I think that is so true, and is something that is brought up constantly as we're going through trainings. I can say as a training director, that is something that's constantly on our mind, is how do we build up these pipelines of clinicians and practitioners so that way it's not just limited to the child population. People are adults a lot longer than their kids, and I love the work that I do, but it's really difficult as we very clearly know that there's that transition cliff that is very, very steep and looming for so many of our families. So I guess the answer here is to stay tuned and, hopefully from evidence through the co-occurring model at the Thompson Center, we really show that this is helpful for our families, and we demonstrate its efficacy not only with children, but its ongoing need for the adult population.
Well, I think the need for the adult population is even greater, Jasper, because if you think about it, as we age, we develop more and more comorbidities, especially in the medical side. And so our kids with autism and neurodevelopmental disorders are going to become adults who've got hypertension. I mean, a host of problems that we don't even treat. Type 2 diabetes, hypertension, endocrinologic problems like with the thyroid. I mean, when you think about that, they have even a greater need in many respects.
Absolutely.
Yeah.
Right. I know. I think everyone's thinking very consciously about age right now from that comment. Okay, next question is, can parents contact directly, or if they feel they're appropriate, or how do our families get in contact with the Thompson Center?
Yeah, well, so right now, mostly because of our limited resource available in terms of clinicians right now, we do have a funnel that is kind of restricts our not restricts, but just kind of funnels in people so that we're not getting requests from all over. So pediatrician referrals are really what we need. We request families to have to get to see us, and usually right now, I believe we're still working through the CHOC primary care network. So kids can get in, families get in if their physician is a primary care network provider, then they have access to us. But we are hoping by the end of this year, we will have enough providers that we will be open for everybody, no matter where, no matter who your pediatrician is.
Great. Thank you, Megerian. Okay, and then we have some questions about slides. Those will be available, so stay tuned to all of our attendees. And then the recording will also be available on our YouTube, typically about a few weeks after the talk is wrapped up. And then it looks like, Tom, we had that other question about if the center accepts Medi-Cal.
Yes, we do take Medi-Cal, yes.
Perfect, great, it's wonderful that the Thompson Center accepts Medi-Cal. And then slides are, yes, as we had said, will be available. And then I think to wrap things up, thank you so much, Tom, for such a wonderful talk. Any kind of last minute takeaways that you'd like to leave our attendees with, families that are in the audience, any of our clinicians or researchers, kind of what is the big, concluding message that you'd like us to leave with today?
I think the biggest thing is remembering that behaviors, when you see a new behavior, it's always important to look for, the whole multitude of causes. And when we think about many of those, they could be medical. And it's important to remember that that complex relationship between disorders like migraines or GI problems, or honestly, even things like kidney stones, remembering that there are medical reasons that kids who have limited communication abilities will try to communicate with you that they don't feel well. And the behavior might not really be just because they're not getting a preferred activity or being asked to do a non-preferred activity. It may be because of a discomfort or medical issue. So important to kind of get that checked out.
Absolutely. Something that we often tell families is, when there is a challenging behavior, to try to understand what the child is really and truly communicating. And I think in addition to the typical functional analyses of attention, obtaining object, sensory, that we do really need to consider the medical underpinnings that might be contributing to this too. So I think that's a great takeaway. Wonderful. All right. Well, last reminder for all of our attendees to complete our evaluation, and that is available in the chat. Thank you so much again, Dr. Megerian, for presenting on the Thompson Autism Center. It was lovely to see you, and I hope everyone enjoys the rest of their day and has a great week. Thank you, everyone.
Bye now.
Bye.